My name is Matt Murphey. I'm a PhD doctor, not a clinician doctor, so I was going to get that out right off the bat. So nothing I say is to be taken as medical advice. I'm only reporting data, but more importantly, I'm here to answer any questions you may have in the general field of orthobiologics, but in this session, more specifically, platelet-rich plasma. We'll talk a little bit about the history and background of PRP, different ways that you can prepare PRP, what different types of PRP are out there, and some of the clinical data and literature that supports the use of PRP. Just kind of by a show of hands, how many people already do PRP regularly? Okay, yeah, that's a fair number. I'm just showing my disclosures just to be up and up. The only relevant disclosure here is that I am a consultant with Apex Biologix on some of their product development. I'll say my background is I'm a PhD in biomedical engineering. So we developed orthobiologic products to regenerate bone and cartilage material, first in little rats and then scaled all the way up to military soldiers. I worked for a number of companies that develop similar products for separating out stem cells, platelets, growth factors that could be derived from blood, bone marrow aspirate, adipose tissue, cord blood. So try to see what the clinical and biological benefits of those things are, and then try to do it in a way that is compliant with FDA regulations. Speaking of which, we're going to have an excellent talk by me tomorrow on FDA. The jokes are free here. But on every topic, I like to just kind of like give a little overstatement about FDA regs, just so you know what the context is for this particular product, what level of safety you should feel about using those products. Generally speaking, FDA regulates all human cell and tissue products under this Code of Federal Regulations 21-1271, and it gets split into two classes. A 351 is considered a major product that has more scrutiny, and it requires FDA regulation, submission, approval, et cetera, before it can be marketed, and in theory, before it can be used clinically. A 361 product is not considered a drug. It's considered low manipulation, low risk. So these are things like any kind of tissue that you take from the patient and give it back to them, assuming a number of other caveats are met, or things like cadaveric tissue. So an ACL graft would be considered a 361. Nobody has to go do a drug trial for a cadaver tissue, right? What's neat about PRP and bone marrow, I'm going to get that next slide, but one of the big caveats is minimal manipulation, homologous use. If a lawyer or a regulatory person ever talks to you, those things are always going to come up. So whatever biologic you use, are you only minimally manipulating it, and are you using it in a way that is homologous or the same function that it had in its source tissue as to the tissue it's being applied to? And FDA in December of 2017 issued a very lengthy set of final guidance documents. CBER is the Center for Biologix Evaluation and Research at FDA, and they gave us some very clear definitions and examples of what is minimal manipulation and what is homologous use. All you got to do is Google that, and the PDFs you can pull up.
I said a real quick question.
Yes, sir.
Is that like bone marrow stem cells to be used for a spine versus adipose stem cell? Isn't there an issue?
Yeah.
Because of the homologous.
Right.
The fat tissue's not.
Yeah. Fat usually it almost always gets dinged on homologous use, and it often gets dinged on minimal manipulation as well.
Right.
But that's a good transition into this, because the beauty of PRP as well as BMAC is that they're not even a 361. The FDA considers it so safe as long as it's autologous, using the patient's own, and you're not more than minimally manipulating it, and you're using it in a homologous manner. It's not even an HCTP. It's just used under the practice of medicine. And then there was concerns for a while of, well, what is the homologous use of blood as it applies to musculoskeletal tissue or bone marrow, for example? There was a debate for a while, like if I'm trying to treat a ligament with bone marrow or platelets, is that a homologous use? Well, I can say that of all the crackdowns the FDA has done over the last 5 or 6 years, they've never done anything with someone doing PRP or bone marrow, as long as they're in a pretty conservative musculoskeletal spine space. Yep. So what is platelet-rich plasma? It'd be redundant for most of you. I should ask you guys what that means. But most simply, it is a concentration of platelets from blood. Of all the different tissues that are commonly talked about, there are a number of regenerative elements that we may want to utilize and harvest. I like to point out that there's no stem cells in PRP because, with the exception of some rare situations that you have a mobilization of hematopoietic stem cells in peripheral blood, you don't see stem cells in the venous blood. So when you do PRP, it's a platelet concentrate, and sometimes patients get confused because they heard about a famous athlete, they got PRP stem cells. I don't know what that means. But PRP is an enrichment of platelets, and sometimes it's an enrichment of white blood cells, which can be good or bad, we can talk about. And it also has the plasma that was associated with that blood that has all kinds of goodies in it that we're going to talk more about as well. There's a number of commercial systems on the market that they themselves had to get FDA approval. So you're using products that already have an FDA approval. You can feel good about that. And most of these processes take no longer than 15 minutes. So it's pretty manageable for a point of care application. Bring patients in, do the treatment, and they're out in the same hour a lot of times. Cytokines is just the fancy jargon for growth factors. This is proteins that elicit some response, usually causing the cells to grow or to move. The most prevalent ones that come from platelets are PDGF, it's the big platelet-derived growth factor, fibroblast growth factor, hepatocyte growth factor, insulin-like growth factor 1, TGF-beta 1, TGF-beta 3. These things are all loaded inside of the platelets. And so you can think of a platelet, right, as just a little kind of dead sack full of growth factors. And at any given time, there's a life cycle of a platelet. It starts to degrade, it releases and gives up all of its growth factors it was carrying. So at any given time, the growth factors in your blood, about 80% of them are locked away in platelets that haven't ruptured yet, and about 20% are dissolved in the plasma from platelets that have already they're already dead and degraded. Angiogenic growth factors like VEGF are very high in PRP, which can be beneficial in times where there's maybe a lack of vascularization or revascularization in some kind of soft tissue injury. You actually want to try to spur on a little extra blood flow to that area. Within the plasma, but not the platelets, we've got a couple of classes of very useful proteins. The matrix-building proteins include fibrinogen, fibronectin, and vitronectin. Fibrinogen is the precursor to fibrin, like a fibrin clot or fibrin glue, right? When we cut our cells and get a clot. What's neat is when we put our PRP back into the body, it could be immediate or over a few days, the platelets degranulate, they activate, and you're going to get some low-level clotting. So it's actually like you're forming the first scaffold on which to get some healing. Fibronectin and vitronectin are just really sticky proteins that cells like to hang on to, like a vine in the jungle. Those proteins will stick to the local tissue, and other cells, whether it was within your PRP or BMAC, or they're just local cells, can stick to it and want to start laying down their own matrix to keep growing up that tissue. There are two very hot topic anti-inflammatory proteins. We'll talk dedicated about them in a second, but Alpha-2-Macroglobulin and IRAP. Do those sound familiar to any people in the room? I think there's a session on A2M here, so you should know that one. There's a Very active debate over the last 3 or 4 years about leukocyte-rich versus leukocyte-poor platelet-rich plasma. You guys kind of heard about this, or you have an opinion, or someone gave you an opinion about one over the other? The first PRP was taking whole blood and the anticoagulated blood and centrifuging it at a pretty high G-force for 5, 10, 15 minutes. The red blood cells would pack tight. The platelets and white blood cells would pack together in what was called the Buffy coat, and then you had platelet-poor plasma on top. When you try to pull out that Buffy coat to get the platelets, you would also get the white blood cells. You'd always inevitably get a little bit of the red blood cells too. So in color, it looked more red. I think it's kind of unfortunate for the poor red blood cell and his mother. He gets the bad name, like, oh, that red PRP is bad. And I think it's just an artifact because the red cells happen to be there in a more leukocyte-rich PRP. I don't think the red blood cells are actually doing anything negative. But you get a pretty high concentration of platelets, but you also get 2 to 10 times the white blood cells that were in the peripheral blood. Versus maybe there's an alternate way that we can centrifuge or otherwise process the blood so that we can get platelets but not have an enrichment of the white blood cells for certain situations where we may want that. I will say that in that process, typically your platelet yield isn't quite as high if you're going to try to avoid the white blood cells. But it does tend to be more of a yellow, amber, golden color. This is a demonstration of 2 ways to make PRP. On top, we have the traditional leukocyte-rich, as I discussed, in excess of 1,500 Gs on the centrifuge for 10 minutes or more, and your platelets are stacked in tight with the white blood cells, so you have one Buffy coat. The other extreme would be do something like less time or less G-force, and you take advantage of the fact that platelets are significantly less dense than white blood cells. Or the other way you could say is they're more buoyant. And if you don't spin it as hard, the red blood cells are the heaviest, so they want to fall down first. And the white blood cells are the next heaviest, so they fall down next. The platelets are the last thing to fall down. And so if you stop short of what you did in the first spin, you can cause the platelets to be suspended in your plasma. And then you could take that and do a secondary centrifugation step that would spin it hard so the platelets would fall to concentrate those platelets. There are ways you can do filtration to concentrate those platelets. There's also an intermediary step, and I think we can probably talk about this later when we do our hands-on, where you're kind of in between on how you spin it, and you actually get a suspension of platelets just above the white blood cells. So you get a quasi-concentration that would allow you to take platelets and a little bit of the white blood cells if you want, but not all of the white blood cells. And why you might want some white blood cells but not others, blowing up what the Buffy coat looks like by the different types of cells, there's no single density for any type of cell. Depending on the age of any of these cells, they can be different sizes, and different weights. So there's an overlap, and for example, if you wanted to get 99% of the platelets, you're probably down here if you cut all of that orange curve, which means you're going to take a lot of monocytes and lymphocytes with your platelet recovery. If you wanted a truly white blood cell free product, and I wish I were about 3 inches taller, we can cut off above that purple, but you may be losing 1/3 to 1/2 of your platelets in order to be able to be a truly white blood cell free. The red blood cells come in here, and so if we try to get all of the white blood cells, that's why we're capturing a little bit of the red blood cells in that product, and it makes it look red. Just for educational purposes, when you spin bone marrow, the stem cells are amongst the white blood cells. They land somewhere between 1.07 and 1.08. So there's no such thing as leukocyte-poor bone marrow, because the stem cells are leukocytes. It defeats the purpose of doing bone marrow aspirate. And we usually see bone marrow concentrate being kind of red, because if you're going to go through the whole trouble of putting a needle in somebody's hip and drawing bone marrow, we want to make sure we get as many stem cells as possible. So we're going to go down and be extra cautious and take a little bit of the red to make sure we got almost all of those white cells. And this box just kind of highlights where, I didn't point this out earlier. The heavier white blood cells are actually heavier because they have more than one nucleus. So they're called multinucleated white blood cells. These also happen to be the ones that are more of the scavenger type to clean up the mess after a wound or an injury. These are macrophages, neutrophils, granulocytes. I think what happened when leukocyte-rich PRP was being injected into inflamed joints, these scavengers were going around looking for the wound to clean up, and it could actually exacerbate the injury, adding fuel to the fire. But in other situations, like with muscle and tendon, you may prefer some inflammation because you've got a local nearby blood supply and the resident stem cell and typed tissue adult cells in that area that can respond to the inflammation and come in and heal. Does that make any sense? It's like in an avascular, in a joint or in a disc, you don't have a blood supply. You don't really want to tick it off by throwing in multinucleated cells. So you want to cut it off with just these mononuclear cells and the platelets. TNC counts. TNC is the acronym for total nucleated cells. This is basically just all the white blood cells. For people that are more serious, they do a lot of regenerative medicine, they want to characterize the biologic that they're using on a patient-by-patient basis, whether it's just as a quality control within your practice, if you want to make notes about it, or if you're actually collecting data for research, publication, or whatever purposes. The easiest way to do a count, even easier than a platelet count, is a white blood cell count. We know that peripheral blood has 4 to 8 million white blood cells per cc. When you're doing a leukocyte-rich, you could expect, depending on how good your system is that you're using, anywhere between 3 and 10 times that level of white blood cell. Of course, if we were to do a leukocyte-poor PRP, you would expect no greater than that 4 to 8 million range, ideally even less. I don't work for or with any vendors that sell these things, but these are obviously relatively inexpensive in terms of like buying a C-arm or something. Systems, I mean, this guy's only like a couple $1,000s, but there are ways that, like right there in your procedure room, when you're doing a lot of orthobiologics, that these things can give you an instant feedback within 30 seconds. It's really an exceptional tool when you get into doing bone marrow applications, more so than PRP. Alpha-2-Macroglobulin, you have a whole other session dedicated to this, so you're probably well educated at this point. It had been around forever, but not really understood what its role was in MSK until a spine surgeon who suffered a lot of injuries in a motorcycle accident about probably 10 to 12 years ago, took a sabbatical and was doing university lab research and started looking at the role of A2M. What they found was that a lot of the degradative enzymes that are present in joints, joint disease, and in the disc, and degenerative disc disease, get bound up by this A2M molecule. So it just locks it up, and then it starts to erode that enzyme so it can't work. If nothing else, it slows down the progression of the joint disease or the disc disease. This molecule also is very effective at binding up TNF-alpha and IL-1, which are the two big pain generators associated with arthritis and inflammation. So being able to capture this A2M can be very beneficial. But A2M doesn't come from the platelets. It's actually synthesized in the liver. So the A2M that we spin down, it's actually in the plasma. When we take Buffy coat, you get a little bit of plasma there with your cells, but if you were doing a large joint, for example, and you could afford to inject 8 or 10 cc's instead of 3 or 4, it's probably not a bad idea to add some of that platelet-poor plasma back, because you're going to get a lot of A2M and those growth factors that were solubilized in. Another molecule that's got similar benefit to A2M is IRAP. Have any of you heard of this before? It goes by another name called orthokine or regenikine. It was popularized by some surgeons in Germany, and Kobe Bryant flying over there a couple times before NBA seasons to get these injections. What they found was IRAP is naturally occurring, and it's the natural rival to IL-1 beta. It blocks the receptor site on sinusites, chondrocytes, fibroblasts, and prevents the chemical pathway from proceeding as part of the that cascade with inflammation. So by having IRAP, you're blocking that signal, you're blocking the pain generator. People feel better immediately but also slows down the arthritic changes. What these Germans were able to do was basically take hot glass beads, you drop some of the patient's blood, shake it up, those glass beads tick off the T cells spit out a lot of IRAP. Excuse me. Later that afternoon, they centrifuge the blood. They don't want the platelets. They don't care about any of that. So red cells go down, white cells go down, platelets go down. They just take the plasma off the top. Now that plasma has more of this IRAP in it. And they do an injection, and they charge Kobe $20,000. What's funny, my own anecdote, for years when people were doing bone marrow, for example, doctors would say, was it a placebo effect? Because I checked in on a patient 48 hours after a knee injection. They're like, man, I feel great. Like, nah, you couldn't feel good that fast. What we didn't know at the time was that bone marrow aspirate plasma has somewhere between 11 and 22 times more IRAP protein in it than the activated blood that Kobe goes to Germany for. So you've got a baseline that's in blood plasma that you can make use of with your PRP. If you go to that next step and do bone marrow, you've got even more of that IRAP protein. And a number of companies on the market offer filter-type devices where you can take that platelet-poor plasma. So when you spend down 60 cc's of bone marrow or blood to make your PRP, you're going to have, give or take, 30 cc's worth of platelet-poor plasma, like the yellow stuff we see at the top of our tubes. We're not going to be able to inject 30 cc's into somebody's joint. But what if we wanted to inject all the proteins from 30 cc's? Let's take that plasma, run it through this filter. The filter basically filters out water. But the proteins are, depending on the size of the filter that we use, the cutoff, the smaller the filter mesh, the more of the proteins that we're going to capture. It's pretty tough to super enrich the IRAP. It's a pretty small molecule in some of these growth factors, but certainly the larger growth factors we're going to get, fibrin, A2M is a very large molecule, so we will get almost all of that when you do a filtration. So it's about, I like to say, using every part of the buffalo, trying to use everything that has a regenerative potential within our blood that we spend down to give back to the patient. Yeah, so you can expect anywhere from a 3 to 10 times enrichment of those proteins if you were to filter down the poor plasma.
What do this cost?
Oh, I don't sell them. I don't know. I think some of the lower cost ones on the market are probably like $200.
So relative to like a $4,000 injection, it doesn't change your cost.
No, that's right.
But it can increase
that's right.
the results.
That's right. You know, like from a business perspective, right. That's a conversation a lot of doctors have because they say, look, you know, did you want a PRP treatment? Well, when you do this, you may be getting a PRP treatment and an IRAP treatment and an A2M treatment all in one, and your costs don't go up. You don't necessarily have to increase the cost that much onto the patient, but they're going to be getting a whole lot more therapy by adding in all of these elements. When you get to bone marrow, it's even one step further because now you get a stem cell treatment and a PRP and an IRAP and an A2M. So we're going to take a few minutes to talk about some clinical data, and then we'll get into the hands-on portion of this session. There's not as much data with PRP as there is with bone marrow, but there's still significantly more data with PRP than basically any other biologic that we would talk about. What has historically been shown from the first days of PRP, that was that leukocyte-rich, it worked really well in tendon and muscle. Hamstring tears that were chronically nagging, epicondylitis was probably the #1 use, and it still is. And although leukocyte-rich PRP, you can get some flare-ups. People tend to have a lot of pain for a few days afterwards. The long-term benefits are actually better than with a leukocyte-poor for these applications. When you talk about doing joint injections, for the reasons we said earlier, we don't want to just tick off the joint that has no way to respond to the inflammation, so the leukocyte-poor platelet-rich plasma is used more in joints. The evidence is certainly growing. We've got a number of papers around tennis elbow, in hips. There was actually been 4 high-powered randomized clinical trials. One of them showed statistically significant advantages over hyaluronic acid by using PRP just intra-articularly in the hip. There is a study by Greg Lutz, who's I think he's PMNR, but he's a spine specialist at HSS Hospital in Manhattan, and he published results that showed basically PRP worked really well if your patients were younger and if they presented themselves pretty early on in the disc degeneration stage. They were the best responders, and he didn't see a difference among those people between using leukocyte-rich and leukocyte-poor. The older the patients and the more degenerated the discs, they're probably more candidates for bone marrow than PRP. In closing, any of these biologics talks I give, I like to make sure that we kind of compartmentalize what these different elements. Are we talking about cells, proteins, growth factors, or something else? Stem cells is one whole class, whether we're trying to drop them in directly or we're trying to indirectly stimulate them by something like PRP. Platelets are just dumb sacks of growth factors that when they hit collagen, they activate, degranulate, and spit out their growth factors. And things like exosomes are just messages, they're information. A cell receives a stimuli, it secretes mRNA or a protein or a cytokine to send a signal to a neighboring cell. But what that message says is completely dependent on the cell that sent it and the environment that that cell was exposed to. So I always kind of caution people, exosomes grown in the lab are not necessarily the same message than what a real stem cell is sending if it was in the body. Yeah. That's all. We've got about 10 minutes. I want to give these guys a chance to show how this device works. I will plug it a little bit by saying this device is elegantly simple. There's not a lot of moving components to it that make it easily fouled up. Whenever you centrifuge it under whatever parameters, if you want a tight pack of platelets or you want the more separation between platelets and white blood cells, this device actually allows you to raise the floor of the tube and push the whole stack up without mixing up the cells after it comes out of the centrifuge. The user can take out as much or as little platelet-poor plasma as they want, capture the platelets or the whole buffy coat if they want, and they can always add more plasma back to that. So you guys can take it away.
What about the usage of PRP